Good afternoon, everyone. I want to welcome you to UCSF Family and Community Medicine Grand Rounds. We have a wonderful treat for you in store this afternoon. We have Dr. Tapan Mehta talking to us about health services and outcomes research to support the quintuple aim in primary care. But before we get started, I wanted to just do a quick few housekeeping reminders. The first one is that the session is being recorded. And if you missed part of the session or you'd like to see sessions from previous times, please feel free to find us on UCSF, Department of Family and Community Medicine, Grand Rounds. If you just Google it, you can watch this session or any other session, which are all uploaded after the fact and great to watch. I also want to give a shout out of thanks to our tech team, to Benjamin and Roy for helping us with some tech challenges this morning and getting us launched onto the right foot. As always, we appreciate you. Today's session is designed to really be an interactive one. So if you have questions or comments that you want to add for Dr. Mehta, this is going to be a very engaging discussion, and I think it made even more so if you really feel free to chime in your thoughts into the Q&A section. We will read them out or ask the questions at any point along the way. And as always, we are interested in hearing your feedback about this Grand Rounds or future ones. So please feel free to use the evaluation session, which we'll put into the Q&A at the end with a link to give us feedback on this session or suggestion for future sessions. So with no further ado, I want to go ahead and tell you a little bit about the session we're going to hear today, which is that Dr. Mehta is going to be talking to us about health services and outcomes research to support the quintuple aim in primary care. Today's presentation will describe the pragmatic study designs and artificial intelligence, machine learning used to develop sustainable and scalable programs to improve population health outcomes and to address health equity. Dr. Mehta will present studies illustrating use of these designs to be presented to our group today and for us to think about together. He'll also share the relevance of these techniques to support a learning health system approach for primary care. Dr. Tapan Mehta is a health services researcher with training in biostatistics and engineering. He currently serves as professor and vice chair for research at the University of Alabama at Birmingham's Department of Family and Community Medicine. He also has a secondary appointment in the Department of Health Services Administration. His independent research interests are in health services and outcomes research related to disabilities and cardiometabolic conditions with focus on knowledge generation in pragmatic settings and strategies in translating knowledge that can influence practice and policy. He's a primary investigator of 2 NIH-funded optimization studies focusing on developing sustainable diabetes management programs to support health equity. Dr. Mehta also leads the Data Coordinating Center for the CDC-funded National Center on Health, Physical Activity, and Disability with the objective of health equity for people with disabilities. And he co-directs the NIH-funded Nutrition Obesity Research Center's Behavioral Science and Analytics. He's published over 80 peer-reviewed journals, and we are just absolutely delighted to have him today. So with no further ado, I would like to welcome Dr. Mehta. Thank you for joining us.
Thank you so much for the introduction, Dr. Venner. It's a pleasure being here, and I would be wanted to thank all of you, Roy, Benjamin, and Ute, for really helping me with the tech support and get started with the presentation. So today I'm going to, talk about some of the work we have been doing related to health services research to support quintuple aim in primary care. Dr. Venner did a very generous introduction of me, so I won't spend much time on that. I wanted to acknowledge the team that is really instrumental in a lot of the work that I would be presenting, colleagues and staff from scholars, trainees from several centers that I'm associated with, and the schools that the School of Medicine, Health Professions, and Public Health, stakeholders that have contributed and enriched our research, which includes patients, community partners, health system partners, as well as caregivers and other organizations. The projects I'll be discussing have been supported by NIH, NIDLR, PCORI, and these are some other disclosures I have around my consulting arrangements. So that's just for all of you to see here. So I'll start with the quintuple aim, which was recently introduced as an move forward from quadruple aim. So the quadruple aim focused on improving or is focused on improving patient experience, improving population health, reducing healthcare cost, improving provider experience. And the quintuple aim has now been focused on health equity, which is such an important uh, area and focus that we all need to pay attention nationally, but certainly in Deep South, where I'm based, this is critical. This is critical for our success. It's part of our mission. It's part of our strategic focus area, given the disparities we see in our communities across UAB and in statewide. I would be going through some other concepts, just introducing ideas and uh, processes that have been placed in at UAB, but other health systems that I've done work around. And one of them is learning health system, which is defined as an organization or network which rapidly analyzes data while incorporating best practice guidelines to directly feedback and improve clinical care. And the idea being, if you look at the idea is over here to use external evidence based on external studies from research to really change practice, track the outcomes within the practice, and create evidence to either further refine that through quality improvement initiatives or to further iterate through research studies to generate evidence, and really doing this in a way which would continuously improve the practice both from a provider experience, patient experience, and population health, as well as addressing the healthcare cost. And now we are also focused on health equity. So the learning health system framework uh, is is critical in that sense, that if an organization that really buys into it can really make progress. And today, what I'm going to discuss are some projects that align with the learning health system and some research designs that could help us bring research closer to the learning health system framework. I would also submit here that causality uh, exists on a continuum. So when we are trying to look at whether a strategy or an intervention is really effective, that evidence of causation exists on a continuum. Clearly, randomized trials are gold standard. Well-designed randomized trials have a lot of design strengths that could help us with causal evidence, which is often what we are looking for. There are quasi-experimental approaches. Then one could look at. There are natural experiments that one could use, and then there is also the improvement science or the quality improvement frameworks uh, that could also generate evidence. And so, from where I see things, sometimes we want to do and we can do randomized trials when we can, whereas there are situations where it's really useful to also use quasi-experimental approaches where we are comparing uh, using observational data really but then using really sound analytic techniques to make comparisons. One of the things I would say here is that for research designs to integrate with a learning health system objective, they and sort of go hand in hand with also quality improvement uh, type of studies. The area one needs to focus on is how pragmatic could we design a study, and really we are referring to effectiveness and implementation science related research here. So how can we make a study very pragmatic such that it can be implemented in real world settings? It's inclusive for broader population, and is findings are generalizable, and the outcomes are relevant then to practice and policymakers, and the burden of data collection is minimal. So likely the data collection happens in a way that is part of clinical workflow with very little minimal data collection done outside the clinical workflow, and in a way also thinking about research intervention as a line of treatment within a clinic. As if some interventions may not be covered by insurance, and I know that changes by state to state sometimes, but the uh, uh, the idea being that these interventions are also a way to provide more access to the patient population. There are uh, ways to evaluate whether your study is pragmatic or not. And one of the standard tool, recommended tool, is the PRECISE tool. And really, it the attributes, the domains that it looks as is, what's the eligibility criteria, what's the recruitment criteria, where is the setting? Is it in a clinical setting, community setting, or is it in a very specific research lab that people are going to come and have to do intervention delivery over there? Uh, what is how flexible it is? And so I think one can then rate, score how pragmatic it is based on these domains, and it's a really useful tool to really look at, from an explanatory point of view, which would be very tightly controlled but not very generalizable study, uh, and not something one can do through the can you all hear me? So one can do through the setting of within the clinic. I think that's really the explanatory is very much in the lab setting, whereas pragmatic would be very much in the clinical or community setting. So I'm going to start with one of my studies that we just wrapped up. This is a PCORI-funded study. It's a pragmatic cluster randomized trial on tele-exercise in multiple people with multiple sclerosis. The motivation here was that we did not have enough access to very specific tele-rehabilitation that needs to be provided for people with MS. So only two centers within the state of Alabama, and I would say in Mississippi, were providing that. Tanner Center was one of the only centers, certified centers. And so there were a lot of barriers in getting access to this treatment. And so we were focused on looking at, can we provide this program in a tele rehabilitation manner, coupled with IVR based behavioral messages, and then asynchronous exercise videos. And the focus was also on sustained effects, so long term effects rather than just a 3-month effect. So we were looking at a 12-month effect that we wanted to study. So these exercises were a combination of neurorehabilitative exercises, yoga and Pilates, and the overall program was a 3-month program. The comparative effectiveness was between on-site care versus asynchronous uh, tele care with weekly calls that participants would get. And we had immediate effect at 3 months and sustained effect at 12 months. The outcomes were actually chosen based on and ranked based on the preferences of our stakeholders, patients, and caregivers, where fatigue, quality of life, and then pain and physical activity were identified as important patient reported outcomes to track. I mean, it was a cluster randomized trial. We partnered with a physical therapy group over here. that allowed us to really work with multiple clinics across Alabama, Mississippi, and Tennessee, about 43, and had broad inclusion criteria with a recruitment goal of 820 participants. The inclusion exclusion criteria was pretty broad. The one I have highlighted here is just like a cautionary tale that when we wrote the grant, we never had this exclusion criteria of people who do not meet the physical activity guidelines, or people who had physical activity guidelines uh, that are met were being excluded. The idea being just recruiting sedentary population. And it's so that this criteria did not exist originally, but as we were developing the protocol after the grant got funded, we incorporated that based on some advice we received. But it's actually turns out from a pragmatic point of view, we should not have done it. We should have kept the exclusion criteria as broad as we could. And there was some noise, and uh, it was difficult to actually operationalize this exclusion criteria uh, in a very pragmatic setting, because in when we are doing clusters, randomized trial in clusters through support groups, those who wanted to participate, they could even figure out like this criteria. I need to score this, uh, less than 24 to make sure that I'm eligible. So which is a good thing, but basically it does affect your. It would have been much better and easier and cleaner, generalizable if this criteria did not exist. So that's just a something for all of us to learn here. And then we had assessments, both patient reported outcomes. We had walking performance measures on balance, gait, such as time up and goes, 6-minute walk test, grip strength, and then also psychosocial outcomes for the behavioral piece around self efficacy, self regulation, exercise, social support for exercise, and outcome expectations, which were hypothesized to be mediators. A lot of stakeholder engagement happened, identifying what the outcomes need to be, but also the choice of like asynchronous mode of telerehabilitation was important because again, the idea being in video bandwidth, internet bandwidth should not be a barrier for people to be able to access the treatment. And so that's why we went from a on-site to an asynchronous form of intervention. Uh, Critical to the success of our recruitment was also a very engaged stakeholder panel. And I bring this up because this is something important from it kept us honest, it kept us in line with like from a health equity point of view, from a research design point of view, for us to make this implementable and being able to translate in a clinical setting, what could we do? And the fact that we were able to operationalize this at 43 clinics is a reflection of some of the really good input we received from our team. This is just a reflection of the reach. Participants from Alabama, Mississippi, and Tennessee, all of we were able to cover vast amount of geographical area. There was a limitation in terms of where the clinics existed. I think uh, that it was really one of the things we learned, that while we wanted to recruit participants from rural areas, or have our sites in rural areas, clinical sites in rural areas, those sites did not exist. So really, it was sites that were in micropolitan areas that allowed us to engage with people in rural areas. And one could see again over here, the ones I have highlighted. For a MS study, we were able to recruit, a pretty significant percentage of Black adult population. So that is from a That was one of the noteworthy point from a recruitment and retention point of view for us. Again, we had about 1/5 of our participants coming from, or 1/4 of our participants coming from non-urban areas, which I would say is micropolitan and rural towns. So, and also people who had a higher level of disability were also, participating in across both arms, and about similar percentages. This is again a distribution of sites, and the from a quintuple aim point of view, where what I would say here is that uh, the sites were randomized. So this was a cluster randomized trial. The sites were randomized for to be either in direct cam or telecam, but each site was trained. Therapists at each site were trained to receive, to sort of know how to provide training, how to provide feedback to the participants if they have questions. So part of this exercise, we were able to train and build capacity across many sites, including non-urban sites, of how do you deliver the specialized exercises that are useful for people with MS across these physical therapy sites, ambulatory sites that were accessible. And these were not specialized sites. These were very, regular physical therapy sites that we were partnering, but we were training their therapists over there. And this study is really very much translatable then to be in any other primary care setting as well. Other things we did from a pragmatic point of view, we were also looking at from a provider burden and participant burden was, there were some guidelines that were out which said, well, one should measure both dynamic gait index and work balance scale in the clinic for people with neurological disabilities. And so we were able to work with certain clinics where there were standardized steps available, and really build a design where we studied whether there was any additional utility of assessing dynamic gait index over work balance scale, uh, which was sort of a nested ancillary study within the main study, uh, in a somewhat rigorous way, to really see whether it's really does it add clinical utility to do this additional test. And what we found, it does not add clinical utility in that sense. So again, thinking about uh, patient care, improved patient experience and improved provider experience, of like how do you minimize the burden of some additional tests that are otherwise being recommended, and how do you test that out in a pragmatic setting. I think this is a really good example of that. Like many studies across the world and in US, we also ran into the COVID issues. It was also an opportunity at that point to uh, really look into whether a synchronous version of direct cam. So we were comparing the asynchronous version, which is telecam, with direct cam. Now a synchronous remote direct cam, is it not inferior? And we compare it with direct cam, but this time using a non-inferiority hypothesis. And this one we did do using a quasi-experimental design. And again, thinking about the evidence, the levels of evidence for causation, we used a quasi-experimental design uh, where we compared our direct cam with direct cam, using a match comparison, using inverse probability treatment weights. And but again, this was also completed as part of the study. So I think the take home from that study has been that a pragmatic cluster randomized trial was needed in this case because of the asynchronous form of intervention, and we were able to do that because of the the way the study was designed and the way it was set up in a way that the pragmatic principles applied largely. I wouldn't say it was completely pragmatic, but it was fairly pragmatic. The next topic I would go into over there in line would be introducing what is called as multi-phase optimization strategy. So the previous one, we are comparing two different interventions head to head. This framework really allows us to look at break down intervention into separate intervention components and then understand which combination of the components is really leading to an optimized intervention. And so it has three phases: a preparatory phase, an optimization phase, and an evaluation phase. And the preparatory phase is really trying to identify which intervention components we need to select to build, to test out the optimization. And within the optimization phase, then there are many designs such as factorial experiment, sequential multiple assignment randomized trial, micro randomized trial, to really then look at optimization of those intervention components and thinking about how do you develop a very sustainable and optimal uh, intervention. And once you have that, there is this whole evaluation comparative effectiveness framework. And the idea being that one can do this in a much more resource friendly manner, because we are, instead of having multiple randomized trial, the optimization phase allows us to look at multiple intervention components in one trial. And I'll give you an example of what that would look like. So one of our ongoing trials is called Food Delivery Remote Monitoring and Coaching Enhanced Education for Optimized Diabetes Management, Freedom Study. This is part of the Forge Ahead Center that NIMHT funded at UAB. I believe UCSF has a research coordinating center for the same Health Equity Action Network. Over here, the focus is on developing optimized multi-level scalable diabetes management intervention to improve glycemic control in uncontrolled type 2 diabetic patients who have suboptimal social determinants of health. And in Deep South, we have racial disparities around cardiometabolic conditions. We have racial disparities in the rates of poverty and social determinants of health, which itself contribute to the excess risk and prevalence or incidence of uh, diabetes and hypertension and obesity in Black adults in Deep South. So what we proposed was an optimization trial here, which was based on a full factorial experimentation. Essentially, we have 8 combinations. If you look at this table, uh, so participants get randomized to one of these 8 combinations, and you know, one combination receives all intervention components, whereas like the 8th one receives only remote patient monitoring. All of them receive diabetes education. So that becomes the standard one. But it's this, if we had to do this using typical standard randomized control trial, it would have required us far larger sample size, as well as it would have required us multiple RCTs to do this. So the idea is to really build a factorial experimentation to understand which combinations of these intervention components are clinically effective. I optimize them based on a cost effectiveness criteria, and then from the implementation science point of view, understand the contextual factors that affect the implementation. Uh, each of these intervention components were focused and targeting specific social determinants of health subdomains. So, for example, mental health coaching was focused on transportation, health literacy, health services access, and quality of care. Monitoring was on transportation and health services access. And then food box delivery was on transportation, hunger, access to healthy food. So the idea was to target these relevant social determinants of health and see whether, which combination of this is really going to be meaningful, clinically meaningful and sustainable. When we designed the study, the preparatory work was really the most preparation work was done during, sort of pre-grant writing and grant writing, and the optimization phase is going on right now. And the idea would be that based on the combination we find, we can then develop a confirmatory comparative effectiveness study to further confirm the findings. So a bit of a most preparatory phase here. Why we chose these three components? These three components were chosen because these are being applied by health systems in silos or in conjunction. So the idea was to really look at whether we can look at the combination of which of these is really useful. So there is data on health coaching that shows health coaching, especially for higher individuals with higher A1C, leads to a reduction, a clinical meaningful reduction in A1C. Similarly, for RPM, there is data around how that helps in reduction in A1C, and both UAB and UMMC health systems have diabetes remote patient monitoring program. And then the food box delivery piece was something that, in my collaboration with Pack Health, which was acquired by Quest Diagnostic, they were working with payers to really help with food box delivery and address food insecurity for payers that had contracted with them. So this was really a way to test, which of these strategies would be most useful in diabetes management. And so it's an ongoing study. We are recruiting currently, but this is a good example of optimization trial that would support health equity and would be resource friendly to be done, aligns with what health systems or peers are either implementing or experimenting, and would help us move forward from a learning health system point of view. Next, briefly, I will talk about a smart lifestyle study that we completed. The idea was to develop an adaptive lifestyle intervention program in primary care using sequential multiple assignment randomized trial. And so, unlike a factorial experiment, the sequential multiple assignment randomized trial tries to look at variability, like tries to look at which intervention would be most useful for what type of patients. So factorial experimentation optimization trial is looking at, on an average, which combination of intervention components across patients is, optimal or sustainable, or, it's whatever optimization criteria is. The SMART trial allows us to develop a adaptive intervention that accounts for the uh, between person variation in terms of responses to treatment and interventions. And Linda Collins and Balney Springs, they are some of the leaders uh, in this area. The idea is to really randomize patients, participants between diet counseling and exercise counseling. The outcome was actually insulin sensitivity. Responder, non-responder status was determined based on an 8-week assessment of insulin resistance that was done. And based on a certain cutoff, if they don't meet a certain cutoff, then the participant was considered to be a non-responder and then re-randomized to additional intervention components such as weight loss and metformin. So this is an example of this is really trying to see, if for somebody, if the treatment is not working, are there other intervention components that can be augmented to improve their response. And this way we could build programs that allow us to use resources on patients that really need those additional resources, while patients who are responding to uh, less intensive approaches you know uh, could be benefiting from those. And at the population health level, then this is a really good design to think about in terms of implementing it for population health management and resource management as well. So going back to the team study, we would be using the same approach of multi-optimization strategy and smart trial to really look at how can now we move back. If you look at this framework, we finished a comparative effect in a study, but we are going back to the drawing board and looking at, you know, who benefited from the asynchronous version, who benefited from the synchronous version, uh, what are the participants really and stakeholders really sharing now based on their experience in this program. And the idea would be to now develop an adaptive tele-rehabilitation program uh, based on a smart trial design that would look at personalized content for behavior change, preferred level of human interaction and support, because there is some balance that we learned would be required between a completely asynchronous to a completely synchronous approach. Developing a pragmatic design, and then can we design an adaptive teams intervention which has low barriers to access and reduced cost. So the optimization framework is a really powerful framework. I just spoke about factorial experimentation and the sequential multiple assignment randomized trial design within that, both of which could uh, help us in the quintuple aim by looking at all the five aspects and building it in the LHS framework. The last few slides I have are on some of the work we are doing within our National Center on Health, Physical Activity, and Disability. This is the CDC-funded center. It's been funded over the last 20 years. I took over the data coordinating center role. We have developed it actually in the last cycle to have a data-driven approach. Uh, so that over here, we have three strategies. The focus is to increase access and promote health equity in people with disabilities. First strategy focuses on health screening and referral, uh, expanding that health screening and referral from primary care and collecting and analyzing data. Strategy two is diffusing and creating access for health promotion programs, evidence-based health promotion programs, primarily using telehealth right now, but that's strategy two. That is to prevent and manage chronic conditions. And third is capacity building. That is to promote and build inclusion through education and engagement with healthcare partners, and how can access and inclusive treatment be provided for uh, people with disabilities. It is sort of important to also note that just a few weeks ago, NIH also included now disability as a health disparity population, which it wasn't for a while. So we have been doing this for past few years, uh, and just happy to see the NIH also adding people with disabilities as a health disparity population. So the infrastructure we have here is healthcare providers, and from my point of view, the primary care providers are referring their patients who have mobility limitations or disabilities to our NICPAD Connect, which has a call center and has a data infrastructure uh, to really track some outcomes. And then these participants get members. Actually, that's not a research program, it's a public health program. So these members get then invited to a mentor program that focuses on mindfulness, resilience, exercise, and nutrition. and we are tracking. So it's one of the first health promotion programs we already implemented. We have others now, like State of Slim and Growth, that are focused on obesity related and mental health related programs. So that programming happens. The members then get also access to health inclusion specialist who can provide them information, additional information, and there is a capacity building core which is really doing outreach to healthcare providers, health systems, to really engage with us and increase the referrals. So that's the basic framework, which includes community and participant engagement and a very clear data coordinating center and evaluation role within the data coordinating center. So one of the approaches we are taking here is again a quasi-experimental approach where we are partnering with a large health center control network, health choice network, which has over 22 clinics across 9 states, and which has 200 locations. So one approach for us is to really, through a two-item screener at the point of care, they will be able to refer their patients to our to NICPAD Connect. In order to do that, we will have educational sessions to all the clinics and all the providers to encourage them. Approach two is to then focus, in addition to that, in approach to focus on 2 or 3 centers where we are actually investing resources to support community health workers to refer people with mobility limitations to NICPAD Connect. And the HCN has its own EMR, which allows us to, it provides EMR to support electronic medical record support to all of these clinics. So it allows us to really track uh, who, which of these strategies is working from a referral point of view. Is one of these approaches really useful? Uh, can we make some changes? Because ultimately we want to go to an approach where this part becomes part of their clinical workflow. So having a central EMR where it's sort of a closed system is really helpful. From a evaluation and performance point of view, we are also looking at the REAIM framework within implementation science, using PDSA cycles to improve our programs and our infrastructure, and continuously investing in data coordinating infrastructure, such as exploring large language modeling now to look at are we able to track themes from our health coaching calls to really understand attrition and understand other aspects of success in the health promotion programs. Some of the outcomes here that we have are around health screening, adoption, awareness and management of chronic disease, and again, reach and adoption. And in case of strategy two, which focuses on health promotion, it focuses on immediate effectiveness and sustained effectiveness and the reach of this program. Uh, Really not much to say here other than we are using REAIM to really look at different aspects. Again, the effectiveness piece is being done using a quasi-experimental design, and the implementation through a mixed methods approach. And the fact that we have a data feed that we could use, and patients, we are collecting data on the members, but the members also have their data uh, through their patient encounters within HCN data feed, allows us to really look at long-term uh, outcomes in the EMR. It also allows us to understand what is the anticipated reach of our program versus what is the observed reach, and really evaluate the referral strategies. So I would summarize that research design could be framed in a way that they can integrate and be along with QI to really influence learning health system, which can support the quintuple aim uh, of improving patient and provider experience, population health, healthcare cost, and health equity. So I think part of that's really one piece of it. There is the second piece of it, that it also then allows us to bring research as an intervention or a line of treatment in primary care to enhance. So some of the work we are doing in NICPAD can be really helpful for primary care, because and in both in health equity for people with disabilities, it can also help patient experience, because now there is a resource that can partner with primary care to provide them health promotion and other services, and it can reduce the burden on the providers in terms of how to address, because there's a capacity building, there is a training piece, but there's also a referral piece to help, and certainly it would then help. It would help population health management. That's all for me today. I am looking forward to any questions you have, and happy to answer and discuss any of these projects or designs and ideas further. Thank you.
Thank you so much. That was a really exciting presentation, and I think really spoke to me, I will just say, as a primary care provider. To me, this is exciting because I think it helps give data and analysis for those of us who practice in an under-resourced setting, to what we already sort of know at a gut level, that health promotion is important, that access is important, that health inclusion is important. And so seeing these numbers really, and these models really make a difference, because I think, for me at least, it helps think about advocacy and how we can actually quantify that. So I guess one of the questions I would ask would be, what would be some additional aspects other than pragmatic design that you would consider to be important for a research intervention to be considered as an additional access or a way to use as a tool for population health management?
Yeah, so one of the things we are doing, and the primary care service line over there is looking at what are the value-based metrics that we need to be thinking about. What is really important for health system from a health system priority point of view, from a CMS quality measures point of view, and really then driving your research in a way that it is addressing those quality measures. So clearly, the Freedom Study addresses that, but there are others. So I think not developing the research studies sort of in silos, but when I now think about the stakeholder engagement, it also engages really policymakers and looking at the outcomes from quality measures, and because then it really starts building access and improving you know building access and potentially improving population health for the health system. Yeah.
Well, this is wonderful. I really appreciate that you've given us a lot to think about, that I think, have opened a dialogue, which will be ongoing for many of us for a long time. I so much appreciate your time today. I also realized that you are presenting from a hotel as you've traveled for a national conference, and I know that you have to make your deadline of checking out of the hotel in time. So I want to make sure that we get you able to meet that deadline. And again, thank you so much for your time today. Much appreciated.
No, thank you so much for inviting me. It was a pleasure, and happy to collaborate and discuss later. We are, if there are opportunities for you to refer your patients to NICPAD, please do so, and happy to share more information about that. Yeah.
Wonderful. Thank you so much, everybody. Thank you for joining us. Have a great afternoon and a wonderful weekend. Thanks. Bye-bye.
Bye.